Happy to be up here with these two gentlemen. I've known them both for a long time now. In fact, the first time I heard the word telehealth or telemedicine was a phone call from Blake, probably back in 2012, 2013, somewhere in there. And I was having dinner at Hula Hut, and you gave me a call. And then here we are all these years later now, and I'm working with Norman MD, and really excited to hear about that. Roger and I have had some various interactions over the years too, for a number of different reasons, and I really respect both of these gentlemen and the opinions they'll bring and the experience they have. So I think there's a lot we can learn from them. So I'll just kick it off by asking you, Blake, to tell us a little bit about the genesis, how you came about to start Cirrus MD with your co-founder. What was the spark? What was the problem you were trying to solve?
Yeah, great. So thanks, Jake, and thanks for having me out, Seth. So I'm an emergency physician. I was born and raised here in Austin. Moved to California, where I still live, and when I became a real doctor, I noticed that my friends and family were constantly hitting me up for advice. What do I do with this issue? And the way that they were doing that is they were texting me, always text, never a phone call, never a FaceTime. It was the way that they naturally chose to communicate with me. So what Cirrus MD is it's a different kind of telemedicine company. We are based in Denver, Colorado, and we've raised money and are about 10 years old now. But the fundamentals of Cirrus MD are that a Cirrus MD patient, with as little friction as possible, touches their phone and they're immediately able to text a doctor. So our physicians respond in under 60 seconds. And we're now up around 10 or 11 million lives with 24/7 instant access to a doctor who they can communicate with right away. And it's really as simple as that.
Roger, kind of the same question to you. Yeah, tell us, if you would, about your journey getting here and how the direct primary care model works for you and the patient, and maybe a little bit of the trends and opportunities you see.
Great. Thanks for having me here, and thanks, Seth and Jake. So I started a direct primary care practice in San Antonio going on 4 years ago. I was practicing in an urgent care in Utah and came across the model. And I saw how it was a refreshing feeling to see that an employer was paying for health care for his employees. And then it was refreshing to see that, because we all know that employers pay for the majority of health care in this country. The difference is usually they do it through an insurance company, but this was direct. So it was so refreshing in that model. We could spend more time with patients, and it just made more sense. So then things happened. I got a master's degree. I had an opportunity to start the clinic in San Antonio, and I did that. We started talking to people about how it works, and everybody's like, wait, what's the catch, because it's so simple and easy. So long story short, we got it started, and it's been wonderful to practice that way. I have a couple of nurse practitioners, have a new doctor starting next week, and so we're growing. It's a wonderfully refreshing way to practice medicine. We can text as well. It's just so natural to connect that way with patients.
Got it. Thank you. So Blake, maybe you could tell us a little bit about how Cirrus MD has evolved over the years, some of the forces at play that led to those changes.
Yeah, so back when Jake and I were first talking about this, we took a hyper-local approach. Our first go-to-market strategy was to try to connect doctors to their own patients. And we started our company, we raised all of our initial rounds of funding with a goal of building a software platform. And that software platform we took all over the country, shopped it to different clinics, small groups, even some large groups. And we said, hey, use this to connect with your patients. Have it be something that the patients pay for. And we came up with a subscription model. And across the nation, in the three large practices that we took that model out into, we sold dozens of subscriptions. And it was a huge fail. So we went back, and people just weren't ready at that time. And the number one question we got was, does my insurance cover it? And our response started with, well, so no words mean anything after that. What we found, right as we ran out of funding, is we found an interesting fit with health insurance. And a small health plan in Colorado called Rocky Mountain Health Plans picked us up. And they provided us as a benefit of membership in the health plan, which was our model for many years. Never really struck product market fit until we started working with employers. And that's where we found our customer. Our user is the person who's underserved by the system. So if a Cirrus MD member is an established patient of Austin Regional Clinic, they've got pretty great health care. They've got pretty great access. It's more or less figured out. Is it texting with a doctor in 60 seconds? No, but they have a doctor and they have a network, and that access is where they go for medical care. Where we really fit is that person who has just moved, that person who has no insurance, that person who just maybe is young enough that they haven't established with a primary doctor yet, but they have needs. And those needs are occasional, or those needs can be chronic. But the underserved worker is where we found our real product market fit.
Got it, okay. Roger, could you tell us about the role that telehealth plays in direct primary care?
That's a good question. So telehealth is kind of, in my mind, evolved into a buzzword. And I say that from the perspective of a direct primary care doc, because the way that healthcare looks for us is we just take care of our patients and we use whatever technology fits, whether it's the phone, whether it's our HIPAA-compliant secure app, or whether it's Zoom through our EMR. So we all know that some folks out there are high-tech and some folks aren't, right, Lauren? So we don't want tech to be a barrier to any of our patients. If a phone call works better for them, we'll just call them on the phone. If we need to do a video visit, we'll send them a link or just dial them up through a video chat with our app. So it works really, really well in direct primary care.
Blake, tell us a little bit about a specific win with a client that you're really proud of that you think would illustrate the value proposition that Cirrus brings.
Yeah, so one of our favorite clients is Target, and so right before the pandemic, we won the contract for all of Target's business, and the win there was unique to our product market fit because we didn't just get their benefited employees, we got the entire workforce. And this was when nobody knew the pandemic was going to happen. We were sold as a healthcare benefit for the hourly part-time workers. And that hadn't been done at any great scale before that contract went in. And it was supposed to be an experiment, then the pandemic happened, then it was made permanent, and that use case has been something that taught us a great deal about a population that we can be relevant into. And so that's been almost entirely mobile in the user experience, whereas the web experience has been something that we've been 50-50 mobile and web up until the Target contract, when that use case is about 99% mobile. And what that means is that we're serving deskless workers. And that's become kind of our buzzword in making a value proposition to companies with part-time workforces, with people who maybe don't even own a computer or certainly don't have one as a part of their job.
What are some of the metrics and KPIs that Target's looking for?
So as far as, there are two big ones. They want to reduce high-cost spend, and they want engagement. So engagement matters if you've got a large workforce of part-time or warehouse or stockers, because there's high churn in those workforces. And one of our favorite numbers that we've been able to produce and that we've been able to measure is that we have reduced part-time workforce churn by 10%.
Wow. Roger, when you look out with direct primary care into the future, what do you see as some of the untapped opportunities? What do you think are some of the barriers that affect adoption that need to be overcome?
There's so many untapped opportunities. It's affordable access to care. So the more that we can get direct primary care out there, the more we're going to get affordable access to care, and that's the greatest opportunity. So some of the challenges are to educate people about it. Like 5 years ago when we were talking to people about it, like I said, we would explain it. Like, you just pay the clinic this small membership fee every month, and you've got unlimited office visits, you've got unlimited virtual visits, and they're like, wait, what's the catch, you know? So just educating people. And then another challenge is to educate employers that that there are options that are affordable. Employers pay so much for health insurance. And I've been saying for a couple of years, well, one of the things that the pandemic taught me is that health insurance is not the same thing as access to health care. It's totally not. But I would submit to you, anytime you're listening to anybody talk about health care, they're probably talking about health insurance, which is so different. I've actually had the great opportunity to go to the Capitol 3 weeks ago and talk about affordable access to care to a special committee that was formed by the House to listen to, for 2 days, people talk about ways that maybe they can change health care. And so through this direct contracting relationship that I have established with an employer in San Antonio, they have about 300 employees. So we're going on our 3rd year with them. We generated a report that shows our savings to that company. So they paid us, and I can talk about these numbers because they're transparent. They're online on our website. You can find them. They paid us about $175,000 for care for this year for this population, and we saved them close to $750,000. And that's documented on our website, you know, kind of how we did that, the details. So that's kind of what I present at the Capitol. I hope they were listening, and I hope they dig into that, and we can develop that more, because think of how many people we could touch. Me and my clinic, we touched 1,600 lives, and we created affordable care for them. Now, what if we could just magnify that throughout the state and the country? I mean, that's the kind of thing that we need people to understand. So the challenge is, how do we get the word out, and how do we realign the incentives? Because, I mean, anybody that's involved with healthcare at a leadership level knows that it's all driven by these incentives, you know, and those need to be kind of realigned to make sense for the patient, first of all. The value in healthcare really starts between the doctor and the patient, whether it's in the room or virtually.
So after cost of care, when you're talking to employers, what's the next most interested, or what's the thing they're interested in next? Is it access? Is it patient satisfaction? What are the other metrics that you report back to show the value of the services you're delivering?
They're also interested in utilization. That's a big one. We have this wonderful graphic in this report that shows a timeline of where we started and their use of traditional health care. And then as time goes on, the line goes down on the graph with time of their use of traditional health care, and the use of direct primary care goes up. And then that translates back into the savings that the employer can realize, because by coming directly, they cut out so much extra cost. So utilization is one thing that we report back. We report back how much time we're spending with patients. Ours is a lot more than the national average. We report, along with utilization, how many office visits everybody has, and the savings. And we report savings on cost of labs, cost of imaging, and avoided care. I mean, we chatted about that earlier. So we also try to keep track of how we're preventing, and we're saving money by preventing downstream cost, by providing access to a doctor. We can prevent people from going to the urgent care or to the emergency room. So those are some of the things we report. And then we're trying to get some reports now that will report on clinical outcomes. But we do have, I can't talk about one clinical outcome that we came across that was really amazing and heartwarming for me as a doctor, and you guys could probably relate. So in this patient population of about 300 employees, since we had this direct care access, we told all the employees, look, if you have anything COVID related, just have them reach out to us and let us manage that. So anything from if they thought it was allergies, if they had an exposure, someone in the family had COVID or they had COVID, or just anything respiratory, anything COVID. So they did, and out of that, 60% of the workforce engaged with us, and we had about 3.5 virtual visits, which each one of those, and here's what's amazing. Nobody went to the hospital and nobody died of COVID.
Wow.
That's amazing,
that
right?
really is amazing.
That's an example of access, what access to a doctor can do. So whatever we can do to provide more affordable access, let's do it.
Yeah, that makes a lot of sense. So, Blake, shifting gears a little bit, how has the pandemic, excuse me, how has the pandemic affected the trajectory of Cirrus MD? Where do you see things landing? I know that it came up with Lauren that one of the questions to Lauren was about how the pandemic has affected volume, and is that sustainable, and how will that change as we move out of the pandemic setting?
So that's a great question, and my favorite metric since we started this company has been our reutilization rate. And so it's not something you hear a lot of people talk about, but in any given month, over 50% of our users have used the system before. And so what that's done for us anyway, since the pandemic drove so many people onto the platform for a first time, they give us this feedback like, how have we not been doing this all along? And so that reutilization continues to be high. And so as we've seen these national numbers kind of level off, ours have continued to climb. And so that's primarily driven by reutilization, which I think of as kind of the great testimony to a product is when somebody, people vote with their thumbs. And so when people choose to come back, we know we've done something that they love, and that's really what you set out to do when you build something.
Yeah, that makes a lot of sense. And that's consistent with what we've seen at Norman MD is whenever, even prior to the pandemic, when we had a flu season, we'd see utilization climb. And then after flu season, our floor was higher. So we had more consistent users after that. And I think the pandemic's having that effect with us as well. Roger, how do you think the post-pandemic era looks for your organization? Do you see that that has a virtuous cycle where it's increased? You think it'll increase utilization moving forward? And how do you integrate that in?
Yeah, so I think the pandemic just proved the model so well, and it opened the eyes to a lot of people. We steadily grew through the pandemic, which was amazing. Our patients didn't lose one lick of access to us. So that didn't go unnoticed. And so telemedicine and access to a doctor will continue to grow. I mean, and it's not going to ever go back to where it was pre-pandemic.
Got it. Blake, I know from the start I was impressed with the way Cirrus MD structured many of their contracts. They were based on outcomes and metrics as opposed to just flat fees and that sort of thing. Tell us more about how contracts are moving when you're dealing with your potential clients.
Yeah, so it's always been some combination of per member per month, kind of like a flat rate across the board based on the size of your population, and then a utilization upcharge of some kind. That's been something that the industry is still developing out. I think fitting into the traditional fee-for-service reimbursement setup has been a challenge in the telemedicine setting, and I think even back to your Teladoc days, there was always some type of mix out there, and that's continued to be a bit of a challenge. But we've settled more in the employer market on a PMPM with some calculus around utilization. So, yeah, kind of a boring answer, but it's something that I think the market is starting to understand more and more that it's going to be something that looks like that.
Yeah, I think that's an issue that everybody in the industry is trying to tackle now, is what does that look like moving forward? And it really is in your model, our model, and Roger's model, you don't always know what the demand or utilization is going to be, so you do have to have some sort of responsive component. Roger, maybe you could speak to some of your contracting, and at a high level, what does that look like? Is it a fixed PMPM? Are there utilization clauses that change some of the reimbursement?
I love the PMPM approach directly, with an employer. We offer our model to anyone, but we do marketing to employers predominantly, and it's basically the same. And it's direct, it's very transparent. You could see all this on our website. We tell them, this is the PMPM, this is what you get, and then all of that's actually listed on the website. Even the pricing for labs is listed in these case reports I talked about. So then after that, if it's a small employer, they usually can just make a decision themselves, but if they're a larger employer, they have a more sophisticated benefit plan, then we might need to get their benefit advisor to join in and help create a more comprehensive plan that ideally it's structured where they have direct access to us through direct primary care, and then when they need a higher level of care, that's where the benefit advisor goes to work, and he'll figure out more the pharmacy stuff, the catastrophic, and the higher level of care, hospitalization, specialists, and all that. But there's ways to do that. But we have to be careful because sometimes the brokers are incentivized on the back end by the large carriers, and they don't always align really well with the company, right?
Yeah, we've noticed that too. So for the last question before we open it up to questions from the group is, I'd love to hear something that's on your radars that we're not hearing about, something that you want to see, something you have seen, something you see in the future with what you're doing and in telehealth in general.
Okay, so I'll tell you I had this kind of realization preparing for that testimony I gave at the Capitol, is that really primary care is affordable, and we don't always need insurance for primary care, because I've demonstrated it that we don't. I've provided primary care for a lot of people without insurance. So I'm not knocking insurance by any means, but we all have insurance for our car, but we don't use it to change the tires, right? So we know how to provide for patients, so we can do that in an affordable way. And that's what we do. So looking forward's the question, right? So I just hope that moving forward, that we can gain notice of direct primary care, and that people can start to use that. Lawmakers and other influencers can recognize the power of it to help people have affordable access to care. Keep people out of the emergency room, whatever works to give people access to affordable care is something that we need to all pay attention to and help grow in whatever sphere we can help influence.
Yeah, that's an interesting perspective. I think a lot of the conversation this morning is centered around reimbursement and legislation, and what you're talking about really is not heavily affected by that.
So I've come to that word reimbursement kind of doesn't sit well with me anymore, because it implies that third party in the room, So the doctor-patient relationship is sacred, That's where real value-based care starts, between the doctor and the patient. And when you really have that, like in the old days with our parents, we had a lot of talk about technology today, That's what we're here to talk about. But in the old days, when we didn't have that, it wasn't unheard of for one of our parents to call up the doc and say, hey, he's got a sore throat again, or he was playing with Johnny who had strep. Can you, and it was done. That was it. So how did we move so far away from that? Let's see if we can move back that way again. So in the world that we practice in direct primary care, we don't have to worry about reimbursement because we're already paid. So we can have unlimited office visits. We can take care of somebody with a quick phone call or a quick text and just move on. Everybody's happy.
Yeah, those types of innovative models are the things that really get me excited too. I think with NormMD, we love the fact that people have access without a copay, that they don't have to think twice. We've broken down those barriers, and so I think that access and uncoupling it from that third person in the room, as you mentioned. Blake, what's on your radar?
Yeah, I mean, what we focus on a lot, and we're growing our physician network almost exclusively with family medicine trained doctors. And pediatricians and psychiatrists, actually. But beyond urgent care is where I think the telemedicine world is going to evolve. And by that I mean the house of telemedicine was built on a single use case, the UTI, okay? But then it exploded with mild COVID. Mild COVID is the most amenable use case to a telemedicine visit that we've ever seen, because it's simple. Stay home if you can tolerate your symptoms. Next. What patients who then came back, they came to us the first time because their employer required a work note for their mild COVID. And so we would provide that, and then they'd say, wow, that was great. And then they'd come back, do you prescribe birth control? Do you have anybody to talk to about my anxiety or my depression? And, I have high cholesterol, but I don't have a doctor. And so we evolved our primary care service so that the 24/7, the always-on, just-in-time service is there, but certain problems we funnel into a primary care continuity-based channel, and we identify those people very selectively. We find people who have problems at a given time in their life that we can be entirely relevant in the management of. And these are people who don't necessarily need in-person care at this point in their life or for this issue. And so defining problem sets and people who are amenable to that type of treatment has really defined our product market fit. And once you're sick or you need multi-specialty or procedural care, that's what your local powerful medical group is going to fill.
I'd like to comment on that because that is so cool to see you guys doing that, because when I was one of the founders of Teledoc, like the first dog doing those visits, we cut it off right here. Sorry, we can't do more for you. We can't order labs and we can't follow up on that. You'll have to go see your primary care doctor. But I always knew it was coming because the way that I always looked at telemedicine is it's not about the telemedicine. It's about the doctor, and like it was already mentioned, telemedicine is just a tool for the doctor. I mean, give you a stethoscope, an otoscope, or whatever. You know what to do with it, and you know what to do with the findings of the lab. So it's so cool to see that evolving to the next level of really virtual primary care.
Yeah, and I think to wrap that up, what I keep thinking of as the theme is access. When we think about, you were talking about your ideal patients and who you're reaching out to and the accessibility that they have. And because of the way healthcare has evolved over the years, we had to put up barriers to access. And I love hearing stories about what you're doing, because it's where people are breaking down those barriers. People who need access are getting it, and navigating our complex system with the help of Cirrus MD and with direct primary care really is an amazing offering for patients. So we appreciate what you're doing. And with that, I'd love to open it up to questions from anybody who has one.
Great. We've got several questions that want to be asked. We'll start.
Great. You all just touched a little bit on this. My name is Anna. I am really interested to hear how you manage patients who need care outside of that virtual telehealth visit. It sounds like we're talking a lot about primary care. And I'd really like to understand specifically if you're seeing patients who are not part of maybe not part of your clinic. How do you manage those patients who are limited by the kinds of services you can provide virtually?
So, we start with giving them access to somebody who can identify if the problem is treatable or if they need to go in for some reason. And having that access in a very low barrier way actually helps to inform the clinical journey. So the discovery happens on your couch, in the middle of the night. You know where you need to go next. And so having a better informed healthcare experience begins with that ease of access and that more intelligent triage. Some of our health plan clients refer to us as venue management. And so if urgent care is okay, then that's okay. But if somebody's having right lower quadrant abdominal pain, we shorten the time to the appropriate venue, which is the emergency room in those cases. And so, ours is a national service. All of our doctors are licensed in between 30 and 50 states. And so we have to try to assess, what resources does somebody have? We always identify what state somebody's located in, but then I ask them what city they're in, because we have people in Alaska off the road system, and then we have people in downtown LA, and we sort of assess what resources somebody has available to them. Do you have an existing relationship with a medical group or a primary doctor, and we go from there.
Was your question, how does somebody have access if they don't have the telemedicine technology?
So what happens when you reach your limitations in that virtual care? So
Okay.
if a patient needs to be seen for, specialty or labs or radiology, anything like that, what do you do
So-
to walk the patient through that?
Yeah, so in our model, they're our patient, and we'll take care of them virtually if we can. At one point when COVID was spiking, we were up to 40% virtual care. But in our model, if they need more than virtual care, we'll just have them come in and do a face-to-face visit. This might be a good place for me to mention also another service that we have internally in the clinic. So when we are getting kind of to the end of our comfort zone as family practice doctors, we subscribe to a service where we can consult a specialist, and we do that electronically. Basically, we present the case to them, and within like 2 or 3 hours, by the next day for sure, we have answers to all of the questions from that specialist. And he'll tell us, I would look for this, and I would look for these labs, or they might say, no, that person needs to go for a biopsy. And that there again is something that some money that the clinic spends for that service for the benefit of our patients to try to keep them from having to go to the next higher level of care. Let me just stretch your thinking a minute and promote what we can do with telemedicine, because a lot of people don't understand this. We had a case during the big freeze that we had. One of the patients reached out on a Friday night, and she showed a picture of how she had this gash under her chin. She slipped on the ice and fell on a rock. This gash was so big she could have put 2 fingers in here. So she's like, hey, this is what happened. I'm looking at that, and what do you say? Yeah, you need to go to the emergency room and get some stitches. But she freaked out. She's like, no, I can't, because I'll get in a crash. Everything is iced over. So what can you do for me now? Well, here's her husband, here's her son. I said, okay, they got hydrogen peroxide, they have butterfly Band-Aids, they got gauze. So she laid down in this place, and somebody was holding the phone, the other was cleaning the wound, and I'm watching them, telling them what to do on this video visit that we're having. And so we got to the point, we cleaned up the wound, we pulled it together tight with butterfly Band-Aids, and then put gauze on that, and it was right under her chin. And so I had them wrap Coban around her head this way, and I said, whatever you do, do not lift your chin up past 90 degrees for a week. And so she did that. I gave her some antibiotics, and when the freeze melted, she came into the clinic. She didn't need, we got by without stitches. She didn't have an infection. She had a great result. So that's just what you can do with access and stretching technology. I mean, doctors know how to take care of patients, and technology is just a tool.
Yeah, and creative problem solving, so well done.
I almost delivered a baby in Louisiana over text message.
Nice.
One question here. First one, I think for Blake. What was it about the employer channel that kind of unlocked your go-to-market? How'd you find product market fit there, but perhaps not elsewhere?
Yeah, so a lot of our big contracts to this day are with Blues Plans and United Healthcare and Aetna contracts, and we see lower utilization among those because we kind of get thrown in there with all the other services that an insurance company might offer. If you go to your health plan's website, you're going to see a smoking cessation hotline. You're going to see the advice nurse. You're going to see a substance abuse counselor. They've got
3
so many
free
things.
gym sessions.
Exactly right. You know, here's your talk space. Here's everything, and so you get lumped in, and they all do it a little differently. And so with the employer, we have taken the success that Target had and bottled it in a way that we say, here's exactly how you communicate this service to your people, and they co-brand with us. And so if you work for Mr. Car Wash or Nordstrom's or iHeartRadio, then there's a co-branded Cirrus MD benefit that comes from your employer, and the big use case has been, again, COVID. Certain employers are offering days off if you get vaccinated. So they would show us their vaccine card, and we'd write the doctor's note to be, to validate that benefit. And then they've used us once, which is that anchor, it's that hook for engagement. And so that's where the strategy with employers has really been a great one for us, as opposed to the health plans.
And then a question about direct primary care. What's the patient population like? Demographically, what's the patient population like?
That's a great question. My clinic is not in an affluent area in San Antonio. It's not far from the airport. And so we see kind of a spectrum. We don't kind of cater to the affluent, so that's not part of our patient population. So it is quite a spectrum, and we do market to employers, so it does kind of get influenced by that. But a lot of them are blue-collar folks.
Is outreach a portion of what you do as well? Are you ever asked to look at that panel of patients and figure out opportunities to meet unmet care needs through outreach?
No.
Yeah. So Blake, is outreach on Cirrus's radar?
So proactive outreach, I mean, that's a great one, and the answer is it's always, been in the product pipeline as far as messaging. The clients aren't asking us at this point to do proactive outreach, but proactive outreach becomes a part of mainly our mental health service. And so we don't do any automations in terms of spamming people, essentially, or giving anything unwanted. But if you become a Cirrus MD primary care patient, then you're paneled out to a specific doctor. They cover each other and they work as a cohesive team. But each doctor proactively reaches out to their own patients when it's time. So, a month, 2 months after we've started that antidepressant, the patients get a text from their doctor.
There you go. Can you just elaborate on delivering a baby over text message?
I didn't actually deliver so this was with a United Healthcare client, and she lived somewhere remote Louisiana, and she came into our app. It's white labeled as United Healthcare Doctor Chat, and she wanted permission from the insurance plan to go to the closer hospital than the one she was meant to go to, which was an hour away, and her husband wasn't home, and she had her kids, and so we actually worked out a plan, and her 17-year-old son came home from the neighbor's house, loaded her in the car, and I said, yes, you can go to the closer hospital because her water had broken. And in that moment, she took the time to get on the United Healthcare app to try to get permission. to do that. And the easiest channel for her was the doctor chat channel, because we designed it that way. There's no barrier, there's no upfront questionnaire, there's no clipboard. You just touch the app and you're instantly into a very familiar feeling environment of chat. And she sent a message and said, my water broke. And yeah, we had that talk, but she was on with me for about 30 minutes as we worked all this out. And so that was that.
Yeah, as I was flying back last night from out of state, I stopped for a second to think about how amazing it is that we get in a giant aluminum tube and we travel across the country. You sometimes forget that, and I think this is another example where you kind of forget that. So that really is a cool illustration of the possibilities of having that direct access to a doctor, which, you know, again, because of the payment models, historically we've put up barrier after barrier, and then where did she go? She went directly to the doctor. Yeah.
I was at a American Telemedicine Association meeting one time, and someone said years ago, our tech has way outpaced our reimbursement strategies.
Any more questions? I'll ask a final one. We're in August 2022. Where do you see telemedicine, telehealth in August 2024?
I would say it's just going to continue to increase, and I feel like the rate at which it's going to increase outside of another pandemic is going to depend on how the incentives are aligned and to promote it, because we've seen that the big grand opening or grand awakening of telemedicine was with the silly pandemic that we had, the unfortunate pandemic. You know, so I hope that now that people's eyes are opened and they've experienced it and see the benefit that it's been, the lives that it's saved, that those incentives can be realigned to continue the growth of it.
So I'll give a non-obvious opinion, and my answer is fewer video visits. And you know, when I look at our platform and all that we're able to accomplish through a text conversation, we convert to video less than 5% of the time. And we only convert to video when we determine that there's going to be a benefit to that interaction being on video. We do a lot of neuro exams on video. We do a lot of pediatric respiratory encounters convert to video. But for the vast majority, if you can communicate with somebody, and you know, one of my favorite stories is of you know, I'm chatting with a woman one day, and all of a sudden she disappears from what had been a steady tempo conversation, and that was okay. I was chatting with multiple people at the same time, and she in about 20 minutes I say, "Hey, you still with me?" ? And I see she's typing, and she says, "Oh yeah, sorry, I'm in a meeting. Can we finish this up in just a bit?" And I said, "Sure, that's fine," because you know, can you imagine being in the middle of a video visit with a doctor or in a doctor's office and saying, "Excuse me, you know, I've got to take this." But she was just, you know, in a meeting at work, and the doctor was there at her convenience rather than the other way around. And so I see more transformation along those lines, where platforms companies, you know, like Norman MD are placing themselves at the service of the user rather than the way it's always been.
And Seth, I'll add to that. I think you'll see more patient monitoring. So I think, you know, the telehealth and telemedicine has brought the physician and patient closer together virtually, and brought the physician sometimes into that patient's home. And then you think about the gaps in care, especially chronic diseases. So the time between when they can see a physician, get back in, the access, the complication. So by leveraging telehealth and telemedicine, you can have more frequent touch points, manage things better, and then you can also have that bi-directional exchange of information asynchronously through remote monitoring. So physicians can monitor what's happening with the blood sugar and what's happening with this patient's blood pressure, or is there something to suggest that their heart failure's getting worse and they might end up in the hospital. And when we look at value-based contracting and the total cost of care, there really is a lot of opportunity in that space to move the needle.